So Peter Lee is the Executive Director of Covered California, where he oversees the planning, development, and ongoing administration and evaluation of the exchange. The exchange was established by the state of California to support the dramatic expansion of coverage enabled by the Affordable Care Act. The exchange is creating a marketplace that will assist millions of Californians access affordable health coverage starting in 2014. Before joining the exchange, Mr. Lee served in the Obama administration, first as the Director of Delivery System Reform for the Office of Health Reform for Health and Human Services, where he coordinated delivery reform efforts for Secretary Sebelius, including coordinating the preparation of the National Quality Strategy. Mr. Lee then served as the Deputy Director for the Center of Medicare and Medicaid Innovation at the Centers for Medicare and Medicaid Services, where he helped establish the new center, which is testing new payment and delivery system reforms that can promote the delivery of higher quality, more affordable health care. Before joining the Obama administration, Mr. Lee led the Pacific Business Group on Health, one of the premier coalitions of private and public purchasers in the nation, first as CEO and then as the Executive Director of National Health Policy. Mr. Lee oversaw negotiations with health plans, quality measurement and consumer engagement activities, and the operation of California's small employer purchasing pool, PAC Advantage. Prior to PBGH, Mr. Lee was the Executive Director of the Center for Healthcare Rights, a consumer advocacy organization based in Los Angeles. In the 1980s, he worked on healthcare issues in Washington, D.C., where he was the Director of Programs for the National AIDS Network. He received his law degree from the University of Southern California. And his undergraduate degree from the University of California at Berkeley. You get both halves of the state, right?
It's a different one in LA. It's funny how
Mr. Lee has served Assurance, the National Quality Forum, the National Business Coalition on Health, and as co-chair of the Consumer Purchaser Disclosure Project, as well as numerous national and statewide bodies, such as the Institute of Medicine's Crossing the Quality Chasm Support Summit Committee and the State of California's Management Health Care Improvement Task Force. Thanks and welcome.
Thanks so much. Good afternoon, or almost afternoon, so good morning. Sorry I missed all of Janet's, but I heard some of Janet's remarks, and getting some of the national perspective is important, but what I want to do in the next 45 minutes or so is tell you how we're doing here in California and what's coming down the track for the fourth open enrollment period. I also want to make sure I go quickly through some slides, but you can download them later so we have time for questions and some dialogue. I heard the question about some of the other carriers and what's happening in other states, and the main thing that I want to convey is really a note of thanks to you in this room. I'm often asked why California is doing so well. And while it's hardly been perfect, it's been bumpy. If you look at what we have done as a state, we really are the poster child for how to make the Affordable Care Act work. With the expansion of Medicaid, with huge growth in the individual market, with premiums under control, with a competitive market that consumers are using, and a key part of that has been the agent community. Through Covered California, on the individual market, almost half of our enrollment is through individual agents, about 45%. And one of the things that I say often nationally, when I'm asked, well, what's going on? Why is California the largest state in the nation, very diverse? It's got rural areas, as you know, as well as urban areas. Why is it working? Well, the biggest reason, I think, is, while we may have different positions on political issues, 2014, California said, okay, this is the law today, let's just make it work. Let's put the politics behind us and say, we're going to invest in marketing, we're going to try to make it work with agents, we're going to make it work for Californians. And that's borne fruit in a lot of ways. So let me now run through a range of pieces, and I'm going to note some of the background, the data that supports that it is working here. But I want to note that from our perspective at Covered California, there's really 4 core elements that make the Affordable Care Act work here. The first is, really, it is about a competitive marketplace. And we have, as you know, in most parts of the state, in the individual market, 3 to 5 health plans to choose between. About 6% of our enrollees only have 2 plans to choose. No one has fewer than 2. Health plans are held accountable by competition. They care about their price position. They care about their benefits in terms of the networks they offer, but having competitive markets is critical. Second, affordable products. Now, I know this is a very informed, savvy bunch. You know that we have standardized patient-centered designs. So consumers know when they're comparing Kaiser or Blue Shield. It's a network issue, not a unclear, ununderstandable benefit design issue. But it's also, for many that have joined, affordability because of subsidies. The growth in the individual market is because of the 90% of the people that have signed on through us who have received subsidies. Third element of success is marketing, outreach, and enrollment. This is where the agent community comes in, but it also is where our work at Covered California comes in. We will be spending this year about $100 million. This is in open enrollment year 4, and not a penny of that is federal money. That's now entirely funded through our assessment on the plans, and it is a good return because it's the cheapest way they can get people in. But we invest a lot in marketing and work with you to do that. And finally, though, we think our success is about making sure people actually get the right care at the right time. Because if people enroll, don't see that they can get access to a doctor, don't get timely care, they aren't going to stay insured. And you know who's going to leave first. It's going to be that healthy person, not the sick person. So that hits the risk pool. So making sure we deliver on the promise by having good care is critical. So those are the 4 elements of our success. So let me sort of go through what that means for us. Well, our business model, those patient-centered designs. Now, I'd note that nationally, the federal marketplace has established almost mirror images of our benefit designs that are voluntary across the nation. Now, when you talk to our health plans, the 11 plans in Covered California, they say these benefit designs work. We don't feel a need to offer other tweaks on them. And for consumers, it means they can do apples-to-apples shopping. Competitive marketplace I spoke to in terms of a real diversity of health plans. We spend a lot on marketing, and we will continue to do that, including a lot of support for the agent community. The federal subsidies are absolutely critical, and one of the things that we've certainly looked at is, as you probably know, there's a presidential election going on. There will be a new president. In a few months, it will no longer be Obamacare. It's going to be someone care. But whatever that is, the subsidies, and whether you're looking at this from conservative perspectives or more liberal perspectives, folks are saying we need to have tax credits to keep the individual market working. That's not in doubt. So the issue of subsidies being critical is critical under any circumstance. We are self-sustainable, so we are not funded with federal money anymore. We had startup funding. That's been spent. We don't get any state funding. We now operate on what is a tithe on the plans that works out spread across the Covered California and off-exchange market to be about 2% of premium. That funds our entire operations, our marketing, our IT, our outreach, and we in California work closely with the Medi-Cal program, which you know has expanded and expanded dramatically. So what are the results we've seen here in California? Well, just last week, the Census Bureau came out with their sort of gold standard reporting that California reduced the rate of uninsured by the biggest percentage of any state in the nation, an 8.6% reduction. That was the largest reduction of any state. Okay? We still have about 8.6% left uninsured. Many of them, though, are undocumented and not eligible for subsidies. We'll never get them. And on some level, with a voluntary program, even with subsidies and penalties, some people are always going to be out of the system. What is the natural rate of uninsured in this new market? We don't know. It's not 8.6. We're going to get it lower than that, but it's never going to be 0. And the issue is that we're moving towards a new individual market that has a good risk mix that's stable. Again, the premium subsidies are critical, and market stability that we've had, unlike other states. And I'm happy to talk about why other states are facing a different experience, but we've made some of the tough calls early on to say, let's make this one marketplace as of 2014. Most of the rest of the nation didn't do that. So health plans didn't know what to price for, and they priced badly, and they lost money. That was not the case in California. California's plans have not lost money. They've done well. In the first year, 2014, our plans in California actually contributed over $200 million to the Risk Corridor program that didn't have enough money to support all the plans that lost money. But those weren't California plans. We contributed to that program. So what have we done? 72% of those previously uninsured now have coverage. But of those eligible, 78% of those eligible for Covered California Medi-Cal are now insured. Okay. Now, we aren't done, but we're well into reaching very deeply into those that are uninsured. How do we do it? We do it with private plans. And these are plans you all know. These are plans that are name brand plans. The thing that we also did in California, though, is and I know this was bumpy in our first year in particular, and many of you have the scars to show it from working with your clients, is Blue Shield, Anthem, in 2014, changed their networks. They started in day one with somewhat more narrow networks than they'd had in the individual market before. That was part of how they didn't lose a boatload of money and have us all be facing in year 2 and in year 3 30 and 40% rate increases. They actually did network design in year 1, thinking about how to make the system be more affordable and not have a rebound effect. We also have Kaiser. We also have some plans that in their area are signature plans like Sharp in San Diego, Western Health Advantage in Sacramento. And we have plans that have traditionally been in the Medi-Cal market that are now moving into the individual market, like Molina, LA Care. But what this means is in areas that have more competition, LA, which is about a third of the enrollment in California, has 7 health plans to choose. Here in this area, I believe it's 4, and it's different in every region. But what we have is real competition, and we've added, as you know, dental coverage and the option for people to enroll in vision coverage. Now, critically important, on and off exchange, same benefits, same price, and really importantly, the same risk pool. And again, this is where when you hear stories of other states where plans have lost a lot of money, they are still moving to one risk pool. So what they've had is people that have been previously underwritten, not part of the Affordable Care Act common risk pool. They didn't know how to price, they got it wrong. We've had from day one a common risk pool. So I'm sure you've heard about our rates. They weren't as good this last year for coming up 2017. The average increase statewide, about 13%. Now, our 3-year average, about 7%. That's a lot better. One of the critical points, though, is the power of shopping. So through Covered California, 80% of Californians can either reduce their premium or have less than a 5% premium increase if they switch plans. Now, you guys know, switching plans, if you've got a relation with a doctor, you got to do some research. You don't want to make sure you don't just switch a plan to switch a plan, but shopping matters. It's driving the plans. It's competition that's driving the plans. We now have plans in new communities. Just down the peninsula, Kaiser, as you may have heard, is open in the Santa Cruz area, an area that has not had enough competition for a long time. We've had some changes in our benefits. Now, with these rate changes, about half people, very low, about half people could be facing over 10% increases. You're going to be busy. I mean, people are going to be coming to say, what can I do? Should I shop? What will I do? Because that half of the people that are facing a 10% or more, they're going to want to consider shopping. Now, remember, these are the rates, though, before premium subsidies. For people who have the subsidies, 90% of the people in Covered California, their change is going to depend on their income, et cetera. But for all the people you're serving off exchange, they're rack rate. They don't have a benefit of a subsidy. So they're going to be coming and asking you for help about what do I do, what are my options, okay? So I noted earlier about the mix of everyone in California has at least 2 carriers to choose. Most have 4 or 5, and we have the vast majority of hospitals and physicians in our networks. But every doctor, every hospital isn't in every network. And it's a critical thing that, and this is the days of big, broad networks that are what are competing with everyone has everyone in, those are gone, to my mind, in the individual market and will be increasingly in the employer market. So helping consumers understand which networks have which doctors, which hospitals is going to be critical. So 2017, again, about half of our plans, less than 5%, 5 to 6%, and Blue Shield and Blue Cross, Anthem, had increases that were in the teens. Why? Biggest single reason is one of the tools of the Affordable Care Act to keep rates low in the first 3 years was reinsurance. Reinsurance was a federal program that had funding through a tax on the entire healthcare system to keep the rates lower in the individual market. That goes away this year. So plans had to build that into rates for 2017, and in particular, Anthem and Shield were hit harder by this. So the Society of Actuaries say this is between a 5 to 7% impact, reinsurance going away. It's a one-time impact. Once it's gone, it's in the rates. Next year, 2018, it won't be there. So that's the biggest single reason. Now, this is, again, where California is different. It isn't in many states where you hear about 30%, 20% increases. That's not reinsurance. Reinsurance is a piece of that, probably 7% plus minus. 7% from our 13 would bring us down to 6 or so, not so bad. But what they did was they priced wrong. Our plans generally have not been pricing wrong. Other reasons, we have some pent-up demand. We're looking at our special enrollment periods that both Anthem and Shield are concerned about being adversely selected against. And there's what we're seeing generally in the nation about specialty drug costs being higher than other costs. So I've already spoken about our portfolio of plans. I won't go through that again. Let me talk briefly about some benefit design changes. And this is actually important. We spend a lot of time working with, and you should know that your representatives at SVAHU are sitting at the table in our plan advisory meetings when we're talking about benefit designs and having the perspective of agents saying, you know, which benefit designs make sense? They're sitting there with folks from the health plan. They're sitting there with consumer advocates. And our benefit designs, and you know, at bronze plan, 60% actuarial value, you can't offer a lot of first dollar coverage. It's not going to happen. Silver plan, which has about 70% of our enrollment, even that, it's a pretty high out-of-pocket you're going to spend if you go to the hospital. But what we've done is develop designs so the vast majority of outpatient care is not subject to a deductible. And this is very, very intentional. Okay, it's intentional because we care about the risk mix. It's intentional because we want people to get the right care at the right time. So some of the changes we made that build on that in terms of first dollar coverage when you see your primary care or your specialty care doctor. First dollar coverage when you go to the emergency room. We've eliminated the emergency room physician fees. We've reduced urgent care copays. We did that specifically because we'd rather have people go to urgent care than to an emergency room. We reduced the copays. We reduced primary care office visit copays. Now, for people that get subsidized coverage, and I know you folks know this, but they also get subsidies on their out-of-pocket, what they spend. At the silver plan for someone that makes, you know, $20,000, they're spending $4 or $3 an office visit. But if you're not subsidized, we want to make sure you still go see your primary care doctor and aren't scared off by that copay. Not at all subject to a deductible. We think this is incredibly important because who's going to leave 6 months into coverage because they think healthcare doesn't have a value? That healthy person. That healthy person is going to say, oh, God, you know, I can't go to see my primary care doc without meeting a deductible of $3,000. Why am I buying insurance? Now, the whole concept of insurance is a complex one. You spend a lot of time on it, but the patient-centered designs are designed specifically to tell people to get the right care, but also to keep the risk pool healthy. One of the other big changes for 2017, and I will note this is going to cause some confusion, but we have about half of our enrollment in PPOs. Okay? Now, historically, there's no such thing, and still going forward, there is no such thing in PPOs as a gatekeeper. But we want everyone in PPOs to know they've got a doctor if they want one and need one. So we're having all the plans with PPO designs to match consumers with doctors and say, here's one available for you. The patient doesn't need to keep them. The patient can pick their doc. They aren't being forced to change by any way, shape, or form. Rather, they're going to be given an access to a primary care clinician that they can turn to. But it's so important that if folks come to ask you, this is not saying that there's a need for a referral. These are not Mother May I gatekeeper doctors. Rather, we've heard concerns of patients saying, once enrolled, I can't find a doctor. We wanted to get ahead of that and make sure that people have access to the right care at the right time, but it's not turning PPO physicians into HMO docs with gatekeepers and prior authorization for referrals. It is, though, going to be a system that we think will help consumers get care when they need it. We think it's the right way to match up primary care providers, which may be family docs, they may be PAs, physician assistants, they may be nurse practitioners. The plans will work with the consumers to do that, but I'm sure in the first couple months of 2017, you might get some calls about it. People may get a notice in the mail saying, we've matched you up with a doctor, and they'll say, I've already got a doctor. This is not a requirement that consumers move. Rather, it's a tool to make sure everyone understands what their options are and they can use the healthcare system. Dental plans. We now have 2 new dental plans. And as you know, dental is a required coverage for kids, the pediatric dental, but not for adults. About 25 to 30% of our adults, though, are buying dental. They're buying that as a buy-up option. It is not subject to the subsidies. It's an important add-on that we think that folks are appreciating. Let me turn briefly now to talk about the small group market. And you folks know this well. There's challenges in the small group market. The tax credit available through Covered California for small business, which is the only place it's available, still not that much money. It's not like the subsidies on the individual market, which are big. And healthcare costs is a mammoth issue for small business. How much a small business can budget to make sure they can offer affordable coverage is tough. Many small businesses have historically switched plans, and that's what they've done, and left their consumers, their employees, needing to be disrupted and make those choices from year to year. You also know that we're coming into the season for the vast majority of small businesses that are going up for renewal. Now, California has more choice in the small business world than any place in the nation. It's both CalChoice and Covered California for small business. We have an environment where businesses have heard more about the opportunities for choosing what they want to pay for, but then allow the consumer to choose what's right for them, their employee. And so at Covered California for small business, we have a multi-carrier portfolio. Employers do the budgeting. They decide how much they want to commit, and then the employees pick whether it's Blue Shield, Health Net, Kaiser, Sharp, and a range of dental plans. Now, I'll note that we at Covered California stumbled in our first year or two with the Covered California for small business. Now, that stumbling, I look back at a lot of things we maybe could have, should have done better. No question we should have done better. But we focused on the individual market. And you may recall when the 2014 hit, that was when healthcare.gov didn't work. Our system worked. I wish we'd done a better job. We didn't. I feel really good about the turnaround we've done. And so today, 99% of new groups are set up in 3 days or less. Okay? 100% of new groups get initial invoice in 3 days or less. 93% of account maintenance is resolved in 3 days or less. And I know this is the brass tacks of what small businesses and also you representing small businesses care about. Getting the brass tacks right is important. We think we've done a very good job at turning those elements around. We've also been looking at improving the portfolio. Starting in 2017, Blue Shield's PPO will be their broad PPO network statewide. This is where the small group market isn't the same as the individual market. It's not the same Shield product that's in the individual market. It's their full-on broad network. Blue Shield will offer also their Trio HMO product. Just as with the individual market, Kaiser is going to be in Region 9 down in the Santa Cruz area. We've also added this year Rogers Benefit as a new general agent to join the other 4 that we have. And we're adding new technologies. Online submission, group administration is coming in early 2017. So let me go through briefly coming up what you're going to be seeing in open enrollment 4, because it's going to be generally talking about open enrollment, some very specific advertising for small group, but a lot of it's going to be generally about getting coverage. So marketing. I noted that we're going to be spending about $100 million in advertising, in outreach, in support for agents. We had a lot of lessons here in California. We know that cost matters, preventive care matters, consistency, peace of mind matter. We also know that for many that have not signed up, they still, and I'm still amazed by this, don't know that subsidies are available. There is still a substantial portion of those eligible for subsidies that think the subsidies are for somebody else. That is a problem. We will be out there advertising with our It's Life Care theme once again, and I'm going to fly through just to get to questions, which you're probably more interested so you'll see a lot of advertising, big spend, but I'd also note that when we sit down with the health plans every year and negotiate around premiums, we also negotiate around their marketing spend. So the plans are spending a lot of money too. The plans are not only in their support for agents, but also their own advertising. We seek to coordinate with that. In terms of outreach and sales, I noted a couple of things that we think worked pretty well this last year. Having storefronts with agents that have Covered California's name on it to encourage people coming to them. Supporting you through webinars, outreach and sales field team, collateral. We want to continue that. We want to build on that by supporting agents through our dedicated service center. Agent and record changes. We want to support our pay now functionality. We continue, and I know you've wrestled with this, we wrestle with this, have challenges of working with our county liaisons. People will always be moving between, some of them, between Covered California and Medi-Cal. How to have that as smooth as possible means we can't flip a switch. It needs to be the county office. So how to have those liaisons work as well as possible so that we want to work with. You know, I noted earlier about the enrollment mix, but I think this is important when we think about our success in California, that 45% of our sales, our enrollment, is through agents. The next biggest area, about 30%, is unassisted. And we say unassisted, chances are a bunch of them actually talk to you, have talked to agents, or talk to people on our phone center, but they end up enrolling online on their own. The next area is our service center. We have over 1,000 people that do enrollment on the phone at Covered California, state employees. And then we have navigators. Now, you should know that the navigators that we pay on a grant basis end up, and we actually look at this, are paid equivalently to what agents are paid. But we target where they are in areas or particular communities that are underserved by agents. And it works out financially similar. We look at what you get as a payment as part of the overall healthcare dollars, just as we look at what we spend on navigators. I noted we have a service center supporting agents. We have dedicated staff to this. We have overflow to our other service center. If we don't support you well, it's not going to work. Now, we've got 50 full-time staff that goes up to 100 during the open enrollment period. We've had an average 2-minute hold time, and I can see any of you will say, I was not average. I was on that call for an unaverage period of time. And you know, this is one of those terrible sayings that you can drown in a lake that's only on average 2 inches deep. It depends on where you are in the lake. But we look at our service levels, and it's something we're committed to try keep on getting you off the phone and back working with your clients. We have grown our sales team, that we have sales regions, account reps, and this is one of the things that we, unlike the rest of the nation, really see what we do as part of sales. We have e-news, we have webinars, the link to these, you can get all these slides and link to them if you haven't already. You know, we are very excited about our storefront program. Almost 600 storefronts. We hope to grow that by about 150 in this next period of time. These are year-round. These are certified insurance agents. We provide listings to them from coveredcalifornia.com. We have toolkits. So we try to do everything we can to give you the tools to be more successful, because that's what's make the Affordable Care Act work here in California. So how have we done? One of the big things I want to note is, to my mind, to my knowledge, we're one of the only states that actually measured where do people go when they leave us. Now, this says 2.5 million consumers served. I don't like sounding like McDonald's. It sounds like we're adding them up every day, but we do add them up every day. Today, we have about 1.4 million who have insurance today. But that means in the last 3 years, 1.1 million have had coverage at some point and left us. Is that a mark of failure or success? The good news is we know where they're going. It's a mark that we are working just as it should be. The biggest place they're going is to employer-based coverage. Exactly what we want a marketplace to be. People are coming to Covered California, some of them for a long time, but many because they're in between jobs. Where else are they going? They're going to Medi-Cal. They're going to private coverage. 85% are going to some form of coverage. They're not leaving Covered California to be uninsured. That's a working health insurance market. That's Covered California becoming part of the fabric of public benefits on the one hand with Medi-Cal, employer coverage, which serves the vast majority of Californians, on the other. You hear a lot about risk mix. And, I noted that would I have rather had an average rate increase in 2017 of less than 13%? Absolutely. But we have the healthiest risk mix in the nation. And risk mix is the driver of health costs in the near term. And our investment is marketing. Our partnership with the agent community is about keeping the risk mix as low as possible. 38% of our enrollment last year were in those young folks of 18 to 34. That's about what they are in the population. So one of the things we all read national stories about in millennials not enrolling, about bad risk mix. This is not a California story. I want to be really clear. What we've done in California is through marketing, through outreach, through good partnerships, is have a good risk mix. Next, though, the near-term way we get good risk and lower costs is a good risk mix. Over the long term, healthcare costs are what the delivery system does. I appreciated Janet's note on the issues of consolidation at the plan level versus consolidation at the provider level. Well, plans need to get the best price for the best value. We actually lean on health plans that we contract with. We don't just sit on the sideline. We say, what are you doing to promote ways to make sure that people with chronic disease get care in a timely manner? We have in our playbook many of the things that I used when I was at the Pacific Business Group on Health, representing very large employers, sitting out with plans saying, this is what we expect you to do to make sure people with cancer are getting timely care, that how you're addressing health disparities, how you're making sure that you're changing your payment to doctors and hospitals to not just reward folks for doing more. These are all elements that we think are crucial over the long term to changing the trends in healthcare costs because we're going to get everyone in, basically. But over time, if we don't change how care is delivered, we're going to have healthcare costs continuing to spiral through the roof. And we think we're on a path to actually help control those costs. So we all have more work to do. I'd note that when I come into open enrollment, there's 3 issues that I think are going to be coming up. First, cost does continue to be a barrier. And I think that this is in particular for those with a smaller subsidy. A smaller and no subsidy, health insurance is expensive. Health care is expensive in America. We haven't turned that upside down. And some of the biggest people we have as challenges is those that get little or no subsidy. This is something that I think we need to face fair and square and know what the benefits are of insurance and help them pick the best insurance for them. For those that are eligible for financial help, we need to help them get it. Again, many of those in Covered California, 90% get financial help. That means their premiums may be as little as $50, $70. But even for them, it's $70 because they make so little money that $70 is still going to be tough. Helping them understand the value of insurance is critical. One of the other factors, and this is more an issue in LA, continues to be concern about immigration status. Is concerns from folks that have mixed families, a family member who's undocumented saying, well, I'm documented, I'm a legal resident, but someone else who lives in my house isn't. Should I be worried about coming and getting coverage? And we need to make it really clear, and we've done it again and again, that immigration status is not something we look at in terms of if you're not eligible, you're not eligible. End of story. But we don't do anything to turn that material over to immigration services. And that's really critical. One other thing that I'd note, you may have heard stories about the issue of California submitting a waiver, also on the immigration issue. So we were directed by the state legislature in a law that was signed by Jerry Brown to prepare a waiver to the federal government to allow undocumented individuals buy coverage through Covered California. I want to be clear, they can buy coverage today off exchange. There is individual plans, off exchange, same product, same price. This is saying let them buy through Covered California, no subsidy. the rationale for the advocates of this, it helps a family all sign up at once, et cetera. We're in the process of finishing that waiver, submitting it to the feds. It's the feds' call to decide. This wouldn't take place for a couple of years. But I want to make sure you understand, this isn't changing the underlying structure of subsidies are available for citizens and legal residents. This is an avenue that might have 20,000 people sign up because of not having the benefit of a subsidy, but it might mean some families are more apt to have the other members of their family sign up. So that's a waiver process I want to touch on, given you may have heard about that in the news. With that, I'd like to throw it open for questions and comments. And I know we have a woman with a mic here, so please raise your hand, and she'll come to you. And if you don't mind, introduce yourself as well as your question or comment.
Hi, Molly Stanford. Does that also mean the Medi-Cal is also not eligible? When you say subsidies, but what about Medi-Cal for the undocumented?
Yeah, it would not provide, Medi-Cal has actually some programs that are very specific for some undocumented today. This has no change to the Medi-Cal rules, doesn't expand Medi-Cal beyond what they have today. This is very specific to unsubsidized coverage in covered California.
Another quick question. Looking at your hours for customer service and having a child that is in covered California, because he's in the entertainment business, you know what that's like. You work and then you don't work.
Uh-huh.
Those hours don't work for him. So I would imagine that the young people with the crazy hours that they have, working 8 to 6,
Well,
even online, if there was online chat or there was something. It seems to me that in this day and age, there should be a more expanded help because there are a lot of questions people have about this.
Great comment. Appreciate it. The hours that we had up there also weren't the standard service center hours that we have generally. Those are for agents. During open enrollment, we have longer hours during open enrollment, and during that time, we also have people doing web chat as well during those expanded hours. Now, and we monitor how many people try to get web chat, et cetera, but it's a great observation. Appreciate it. Sir?
My name is John Palladino. I have two small gripes. One, group. Your shop pays commissions very, very, very slow. I have groups that are out 3 months. What can you do to get us paid on time?
Great. So we've, again, this is one of those notes of stumbled, and it's getting better. Not perfect, but we're getting payments out a lot faster now, and I think we're working to get to a place where we should be very close to on time. And I want to be on time all the time. I mean, this is where we recognize this is your work and effort, and getting you the commissions for that work, something we are absolutely committed to do, and we're speeding it up, and we will be on time. So,
What do you consider on time?
well, I'd look at sort of market standard for in terms of the specific time. I'm not sure. What do you consider on time?
30 days.
Okay. Well, it's all a matter of the 30 days from when the reports get to where and process through. So we'll do what we can.
Not 30 days from payment.
Okay.
The other one would be, I'm having problems with the group, let's say HealthNet, having a full network, and then HealthNet having a smaller network on individual.
Mm-hmm.
When doctors are calling in, they're getting the wrong information.
Yeah.
They're getting your doctor, your whatever facility is not part of the new HealthNet skinny network. How can we get it to the point where we're getting correct information?
Yeah, that's a great question. And one of the things that we're working with the plans on is actually a state law that plans have accurate provider directories specific to the plan you're in. And that's actually rolling out this January, where plans are being held to account not just by us, but this is not just a Cover California issue. This is where it's an issue in the individual market writ large and the small group market. There's different networks. Understanding which one you're in and which one you're not is a huge issue. We had hoped to actually have a common provider directory on our website this open enrollment. We aren't putting it up. We're going to wait a year because each of the plans are updating their provider directories so they're more accurate. We wanted to make sure they got it right before we rolled it all into one. So, and we're looking at that very closely. It also is, though, we've been working with the CMA, the California Medical Association, because some of this is truly on the shoulders of those doctors' offices. It's their job to understand which networks they're in part. And so we're working not just with the plans to make sure they get the directories right, but also with the physician community to say, your front office staff need to be clear, because we've had miscommunications from front office staff. It's their job as well. So that's what we've been pushing for as well. Thank you, sir.
I'm Pamela Fugit-Hetrick, and I'm one of your storefront locations in dreaded Area 9 with the 28.6%.
Well, hopefully less
rate
dreaded a
increase.
little bit now,
Oh,
but
no, bad this year. 60% of our doctors are in one specific network, and we're in contract negotiations with the last PPO left standing. And it's quite a possibility that those 60% will not be participating in any covered California plans, in spite of the 28.6% rate increase. So are you assigning these primary care doctors based on information that exists today, or what's going to exist with this big evacuation of doctors for us?
well, I mean, we look closely at, and the plans work with us. If they've got what they think are going to be changes in the doctors, they'll need to let us know, and we'll do that. But the issues of, I mean, I'm not sure the specific negotiations, but Region 9, as you know, is a very, very tough region and has been for all employers for a long time.
Yes.
And the providers that are negotiating to their benefit, often it's to the benefit of the networks that they're providing to, our
That's
members,
our
et cetera.
biggest region, or why we lose clients, is there's no doctor to go to. It's not even, the cost is always part of it, but that's probably the next biggest reason. You can have insurance, but what do you do with it?
Yeah, absolutely. I mean, this is where the PCP matching will be, if their networks change, the plans will need to go back out and find a new one that is local to them and update it, but they'll be working on their current rosters, and we'll update it, and I'll actually follow up with our plan management team to see where they are and tracking what's going on in those negotiations. Thank you.
Hello, Peter Lee, Michael Lujan, SVAHU and SVAHU. Quick comment and then a follow-up question. The comment, many of our members aren't aware of the work that was done on behalf of the Covered California Board that helped support some really important initiatives that support agents. Helping agents get paid evenly across different products during SEP, supporting agent of record changes and delegations, a whole bunch of things that I think are really helpful for brokers and actually apply both on and off exchange, because these are QHP agreements and they apply both ways. So first, a pause to thank you for that support and helping agents with fair and sustainable compensation.
Thanks. Well, I would note one thing on that, Michael. That your question is we had a plan come to us and say, we are going to implement a policy of not paying agents during special enrollment. And we said, no, you're not. And this was in the face of these decisions being made in other states, and that's taken effect in other states. California and our board being behind the agent community was the right thing to do on a lot of levels. But a big one is that sales is year-round. Supporting the agent community is a year-round proposition. And we think it's actually, on a plan's perspective, penny wise and pound foolish to not be thinking about risk pool by having good, engaged partners in the community. And we're very public on this. We've been public nationally. We think it's a worry of what we're seeing in other states that have not taken what we believe is a more enlightened approach. But thank you.
Well, we share that concern and appreciate, there was also a letter to Secretary Burwell that expressed that concern around agent compensation. The question is, and as professionals in the industry that understand insurance concepts and the tension between having a open self-attestation process for SEP, so when someone says they move or someone says they lost a job, they sign a form or an affidavit that effectively attests this happened. But there's also some, at least suspected, or if not real, gaming of the system. Can you speak to what impact you think that has on rates? We're wrestling to try to keep rates at a reasonable level. SEP has some impact. Can you speak to what we can do to curb that?
Absolutely. So first, special enrollment, from our analysis, and we've got some really good actuaries, will always be a somewhat more expensive population than open enrollment. Because if you've lost a job, you're more likely to say, I'm going to switch over and get insurance if you've got a health condition than if you're healthy. If you're healthy and you got 4 months to go, say, oh, wait until I get a new job. So it's always going to be somewhat of a less healthy mix. The concern we have, we think it's a real concern, we've seen from a couple plans what appear to be potential of folks gaming the system in one way or another. Now, we're doing right now a review of electronically what can we do to verify. The biggest reason that people are eligible during special enrollment is they say they've lost coverage. Loss of coverage can actually be electronically verified. And so we're looking at setting in place systems to do electronic verification. Similarly, on the move issue, we're looking at what documentation requirements we might put in place, how to do that, how to make it timely. One of our big concerns is we want to set in place processes that would, as much as possible, be pre-enrollment, not post-enrollment. The last thing we want to do is get people into coverage, starting to get care, and then trying to have a rescinding their coverage. So what we're looking at as much as possible to get pre-documentation process, and that takes some time. We're working with plans, we're going through some vendors to see what we can do to do each of those. Thank you. Anyone else? There we go.
Hi, my name is Mickey Trevino, and I just have a concern about the subsidy. So it's my understanding that when an employer offers and contributes toward the premium of the employee, that it disqualifies the dependents towards the subsidy. And there's just low wage earners that can't afford dependent premiums. So I just wanted to know what the reasoning was behind that.
It's a really good question. You're referring to something called the family glitch, which is it's actually in the law, when I say in the law, in the Affordable Care Act as passed by Congress, which looks at an individual's income and their being eligible for coverage and applies that to an entire family and could disqualify the family for subsidies. So when we've been talking to folks in Washington, there's a lot of things being bandied about potential changes and improvements in the Affordable Care Act. And remember, for the last 5 years, the discussions haven't been on let's fix glitches in the law. It's been a sort of a on and off switch. It's let's repeal it, or it's all great. It's not all great. There's things that need to be improved. And there's getting rid of the family glitch is one of the things that's on the table that a new administration is absolutely going to look at. But it's not something we can do in California. It actually requires literally a change in the law, and it's one of the things that we've actually modeled in California. How many more people would get coverage, and it would be like 100,000 people would likely get more coverage in California if that glitch were gone. But there's a range of other things that are being looked at, and we have to look at the range of either increasing subsidies or decreasing subsidies. What would each of those look like in terms of the impact on enrollment? And again, I noted earlier, and I'm not a crystal ball person relative to presidential elections or whichever, but I am, I spent time in Washington with both sides of the aisle, and when you get out of the limelight and you get, thoughtful leaders of both parties, they're saying, look, the Affordable Care Act is working on many levels. And I was one example of this, I was actually testifying before the House of Representatives about a month ago, and there was 4 people testifying. And actually, one of the representatives was from SVAHU. 2 others were called by the Republican majority, and I was a witness called by the Democrats, so I don't represent them. One of the questions was, would anyone who was, and the 3 witnesses who were there representing more conservative perspectives were all asked, should we repeal the Affordable Care Act? Every one of them said no. And so the discussion when you get beyond the election is about how to make this work, including fixing things like the family glitch. Now, I'm afraid after this question, I'm going to have to call on you. Otherwise, everyone at this table won't have asked a question. But it shows that front row kind of mentality. Please go ahead.
Sorry.
No.
Jeannie Jacobs from Pinterest. I'm wondering why you restrict shop purchases to touching metal tiers.
Say again?
Why you restrict the purchases within the shop of touching metal tiers.
Great. So the question, why do we allow only bordering tiers, letting an employer pick silver and gold or silver and bronze? This is because the plans say that if we don't do that, they would price it much higher. And so it's a price issue. The effect on premium, if you were to offer a bronze and platinum, that would enable potentially a business owner to offer platinum or only have very sick people buy platinum and all others buy bronze ends up affecting the risk mix and the cost. So it's because of the driving point from the plan saying, would we rather have a product that is significantly more expensive or narrow bands of choice? Okay. Any other questions? Well, I want to thank you very much for having me here. Thank for the work that you're all doing, and go team for open enrollment number 4. Thanks a lot.